listen-only mode.
Okay, Prof, you can go.
Good evening. Welcome everybody. Leon van Rensburg, RSSA Congress Director. It's my pleasure to welcome you all to the next lecture in our head and neck series, presented by Dr. Richard Wiggins III from the University of Utah, Salt Lake City. Dr. Wiggins is Professor of Radiology and Imaging Sciences at the University of Utah and an adjunct professor in the departments of otolaryngology, head and neck surgery, and biomedical informatics. He's currently the program chair of the Society of the Imaging and Informatics in Medicine. Dr. Wiggins is CAQ certified in neuroradiology by the American Board of Neuroradiology and is also certified by the American Board of Imaging Informatics. At this stage, also need to tell you about the Utah Head and Neck Conference that will take place on March 25, 29th in Salt Lake City. You can Google it on Head and Neck Conferences. Dr. Wiggins has gracefully extended a special invitation to RSSA members with a 50% discount on registrations, and he can also assist with accommodation recommendations. I realize it's a short notice, but for those of you who really want to pursue an career in head and neck imaging, if you can by any way use this opportunity to attend the Utah Head and Neck Conference, please do that. Without any further delay, it's over to Dr. Wiggins, and thank you very much for your time and your commitment to South African radiology.
All right, thank you, Dr. Van Rensburg. This is Rick Wiggins again at the University of Utah. So our next lecture for today, we're going to be talking about just top 10 imaging pearls. So we have just some ideas and kind of what I've learned over the past 25 years or so of my head and neck imaging lecture series. So I'm going to be talking today about some about misdiagnoses, but also different ways to think about how we image the head and neck. And I've just kind of randomly grouped these different areas into 10 different imaging pearls that we talk about. So I'm going to start off with the importance of T1 pre-contrasted images, and we'll talk about lymph nodes, cranial nerves, prior reports, sinus disease, history, anatomy, tumor spread data. These aren't in any necessary order of importance, but it's just some ideas that I've had over the past couple of decades of my career that I think are important when thinking about head and neck imaging studies. So we're going to start off with T1 pre-contrasted images and the importance of looking at where there's fat in our imaging studies. So the idea here is that fat is your friend. So just like when we're looking at soft tissue neck studies, it's very important to start off with a window level setting, something like 440, so that air is different than fat. And when I look at MRI studies, I look very closely at the pre-contrasted T1 images, because those are very important because I can see where there's fat. So I want to be sure that I do not do pre-contrasted fat saturation images because I want to see where that fat is on the images. So often I found that the pre-contrasted T1 images are even more important than the post-contrasted for head and neck. And at my own tumor board every Friday here at my shop, I often pull up the pre-contrasted T1 and pay more attention to those than the post-contrasted. Because I know in the extracranial head and neck, where there is air and where there is fat is very important for a lot of these pathologies. So I pay very close attention to that. So this is an axial T1 pre-contrasted image. And I look at this and I see that the turbinates in the nasal mucosa are very dark. So I remember that the nose knows. So I know this is a pre-contrasted image. But it's very important when I look at all the fat and the retromaxillary fat pad and the fat marrow within the bones, the condylar head and the pterygoid plates and the central skull base, if I have replacement of that fat, it's very important for a lot of the pathology in the extracranial head and neck. I can also see important structures like the cranial nerves. I know that when I find the condylar head and I find the medial portion, if I go a centimeter medial and a centimeter anterior, that's going to be where V3 is coming out below ovale. So I can see this anatomy very nicely on the T1 before contrast. Here's just another picture where it shows the importance of the parapharyngeal fat crawling up the skull base. And it's very important to see where that fat is and how it's displaced. And we talked about that a little bit in the superhighweight neck. I want to find that parapharyngeal fat and see how it's displaced on the axial T1 images. Those are very important. So here I've outlined the parapharyngeal space with that complex fat. And as we talked about last month, where that fat is displaced is very important. If I have a lesion along the pharyngeal mucosal surface or space, I can see how that fat is pushed back posteriorly and laterally when I find that parapharyngeal space fat. If I have a lesion in the masticator space, I know that that fat is pushed medially and posteriorly. So that helps me guess this lesion is arising from the masticator space. If I have a lesion of the parotid space, I see that fat is pushed medially and anteriorly, helping me guess that this lesion is arising from the parotid space. And if I have a lesion arising from the carotid sheath or the carotid space, I see how that fat is pushed anteriorly. So I can think about the origin site of pathology and then make a space-specific origin, and then I can make an imaging differential based on those imaging findings. So I think very closely about the fat and the extracranial head and neck. So those pre-contrasted T1 images are very important for me, and they're much more important than sometimes the SPGR or the FSPGR or the MP-RAGE imaging that may obscure the fat in the marrow and the bone or in the extracranial head and neck. So every time I'm looking at a superhighway neck study, I find that fat. And I know if a lesion is arising from the different spaces around those fat, it'll push that parapharyngeal fat in different directions, and that helps me make a space-specific differential. And then I can assign the imaging features to pathology that happens to anatomy of that space. So it's very important that we make a space-specific differential with our imaging diagnoses. So we can be much more specific rather than where we were 20 or 25 years ago, where we would just say there's a mass in the deep spaces of the neck, and we would list 10 or 20 things that were possibilities. Now I can make a much more specific differential on my imaging studies. It's also very important for perinodal tumor spread. When I'm looking at subtle studies, I look at the fat in the subcutaneous tissues, like we talked about the SMAS last month, the superficial muscular aponeurosis space, where we have the subcutaneous fat in the voluntary and involuntary muscles of facial expression. If I've replaced that fat, like this skin squamous cell carcinoma, and I see perineural tumor spread that's actually crawling on V2 on the infraorbital nerve back towards the retromaxillary fat pad and the pterygopalatine fossa, that pre-contrasted T1 is very important to evaluate this pathology. I also want to pay very attention to where I think there is enhancement and where I think there is no enhancement. This was a study that looked like it had bilateral enhancing lesions that somebody thought was a venal lymphatic malformation on the post-contrasted images. But if they had looked at the pre-contrasted, they would have said there was just normal fat at that location. So it's very important to pay attention to where that fat is. Don't ignore the pre-contrasted T1. Sometimes they're more important than the post-contrasted. Now, sometimes loss of fat saturation can be very confusing for us. This case was thought to be an enhancing lesion at the pterygoid plates. And if you look closely, you can see we've actually lost our fat saturation of the subcutaneous tissues. And if they had just paid more attention to the pre-contrasted T1, they would have seen that this area was actually bright before a contrast. So I remember the nose. On this post-contrasted image, the nose is bright, so I know that's post-contrasted. And here the nose is dark, that's pre-contrasted. so I know where there is contrast and where there is not. Here's another case where on the post-contrasted imaging without fat saturation, it's hard to see a specific lesion anywhere, but that lesion is pretty obvious if we look at the pre-contrasted T1 to see this preauricular mass, or if we do our post-contrasted with fat saturation, we want to be very wary of lesions that may enhance the same degree as the surrounding tissues, or that may look a lot like fat on the post-contrasted imaging. So it's much easier to see this lesion on the post-contrasted with fat saturation, or here before we even give contrast on the pre-contrasted T1. Just another example very quickly to finish the importance of T1. Here is a case that on the post-contrasted, it wasn't clear exactly where the lesion was or if there was a lesion. But if we look at the pre-contrasted T1, there is an obvious lesion here within this parotid. And this was an oncocytoma, kind of a vanishing tumor that may kind of hide when we look at those imaging studies. So the importance here is don't ignore the pre-contrasted T1. Fat is your friend. And where there is air and where there is fat is very important in the extracranial head and neck. So next we have lymph nodes. We're going to have a whole lecture on lymph nodes later in this lecture series. But the important thing to remember about lymph nodes is that it's not really just about size. That's the important thing here. A lot of articles have been written about lymph node maximal longitudinal diameter or minimal diameter in different areas, or even the ratio between longitudinal and latitudinal diameter. But it's actually much more important to think about other characteristics of the lymph nodes themselves and the cervical soft tissues. And this is a big deal for us. There's more lymph nodes above the clavicles than there are below the clavicles. So it's very difficult for us in the head and neck imaging world. And in reality, the single most important prognostic factor for squamous cell carcinoma of the head and neck is not actually the tumor site or the tumor size or even the differentiation. The single most important thing that we think about for prognosis is actually the presence and number of pathologic lymph nodes. So when we think about things like losing the fatty hilum, and does the lymph node look like the other lymph nodes? Are there low density foci within it? Or is there fuzziness around the outside of the node, like extracapsular extension or extracapsular spread? Those are much more important factors when we think about lymph nodes themselves. And we're going to have a lecture on lymph nodes later in the year, specifically talking about their imaging characteristics and locations. So the next issue is cranial nerves. Anytime we're thinking about cranial nerve evaluation, we want to think very importantly about the anatomy of that nerve. So if we just have a patient who has a significant pathology, if they're not moving the right side of the body and we're thinking about ischemia in the brain, that's very different. But anytime we have an isolated cranial nerve deficit, we want to think about imaging all the way through the nerve. So from the origin nucleus all the way out through the end organ. So in this case, we think about the fifth nerve. We'll talk about that more later. But all the central cranial nuclei that make up the fifth nerve, and imaging all the way out through the end organ if we think about a pathology along the cranial nerve. So it's important here to remember thinking about imaging from the origin nucleus all the way out through the end organ for each cranial nerve, anytime there's an isolated cranial nerve deficit. Now, that may be very different if we have a patient like this case where there's a large squamous cell carcinoma of the face. We see on this post-contrasted CT and the correlating post-contrasted MRI. But one of the things we want to talk about anytime we have a head and neck cancer case is where is the lesion centered, how big it is, where does it go, and what does it invade in terms of the surrounding anatomy. And then we look for peritoneal tumor spread and lymph nodes. And as we see on this case, there's actually spread along the infraorbital nerve, along V2, back to the retromaxillary fat pad, through the pterygomaxillary fissure, and into the pterygopalatine fossa. And this case actually has extension back along V2 and through rotundum. So that's very important in terms of peritoneal tumor spread. That may significantly change this patient's prognosis as well as their therapy. So we look on the CT to find out where there's normally fat in the pterygopalatine fossa. and we want to window the CT so that fat is different than air, so we can differentiate that. But we look for replacement of the fat of the pterygopalatine fossa. That's a very important way station of the deep face. We'll talk about more in upcoming lectures. But we look at the post-contrasted imaging for perineal tumor spread. And if we're looking at the pre-contrasted T1, we think about loss of fat along the nerve itself. Under every foramen of the skull base, we want to see a nice fat pad. So for each of those cranial nerves, we think about imaging from their origin nucleus all the way out through the end organ. And we can think about the middle nerves, 5 through 8, having their origin within the pons, 1 through 4 being in the midbrain or mesencephalon above, and 9 through 12 being below in the medulla. So for example, if we think about a cross-section of the pons and where the fourth ventricle is posteriorly, we have the central cranial nuclei below that. So the sixth nerve is immediately in front of the fourth ventricle facial colliculi, those bumps on the front, and the fibers of 6 come out anteriorly at the pontomedullary junction. The fibers of 7, though, that motor nucleus, are anterior and lateral to the motor nucleus of 6, and those fibers do kind of a strange thing in that they start the opposite direction and they wrap around 6 to go out through the inferior pons ventrolaterally. And they actually pass in between the superior salivatory nucleus and the solitary tract and join those fibers. So anytime we have a cranial nerve 7 problem, we want to think about as a isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So that means imaging the pons in the central area as well. So if a patient has a multiple sclerosis plaque or a lesion in the cerebellar peduncle and the brachium pontus here at this level, we can understand why that patient may have a 7th nerve deficit. Or if the patient has a pathology like a cavernous malformation, here we see in this case on the T2, old blood pushed to the periphery, very dark on the T2. There is some blooming on the gradient. We have a little bit of T1 shortening, bright T1 signal consistent with blood products, and we do see some enhancement within this cavernous malformation. You could understand why this patient may show up with a facial nerve paralysis because those fibers of 7 are passing right through this lesion. We can also get nerve sheath tumors like a schwannoma that may happen along this lesion. And when we talk later about the 7th nerve, we'll talk about the different imaging features of the 7th nerve schwannoma, how it may occur along different courses and different segments of the facial nerve itself. And we may see very different imaging appearances based on which segment the facial nerve shows up along. We can also have trauma with fractures. So we know that if we have a fracture like this, a nice example of a transverse fracture that is involving the otic capsule. So this is a otic capsule involving transverse fracture. If the fracture extends along the temporal bone, we sometimes call that a longitudinal fracture. So this is a transverse fracture. We can understand, though, how that might also affect the cranial nerve segments, in this case, the labyrinthine segment of the facial nerve. And again, we have perineural tumor spread. Anytime we have tumors spreading along a cranial nerve, that may cause a cranial nerve isolated deficit for that case. And this is a nice correlating case where we see a tumor within the parotid gland itself that's extending up the descending or mastoid segment. We see here before contrast on the left side of your screen and after contrast on the right side of your screen, where we see the enhancing lesion within the parotid and the perineal tumor spread extending up the descending or mastoid segment. Now, again, we'll talk about cranial nerves more in later lectures, but there are some areas where they come together. We're often talking about cranial nerve 5 and cranial nerve 7 when we talk about perineal tumor spread. And there's an area where 5 and 7 come together on the auriculotemporal nerve that connects 5 and 7 below ovale and in front of the stylomastoid foramen. And this is just a nice example of a perineal tumor that was crawling along that auriculotemporal nerve connecting 5 and 7 on this post-contrasted MR. So anytime we think about cranial nerves, we want to think about imaging from the origin nucleus all the way out through the end organ. So the next important subject here on the top 10 imaging pearls is the importance of prior reports and that prior report example. Now, I try to remember to stay objective, even if I was the person who read out the prior report, or for example, if I did the prior study, I don't necessarily want to believe everything in the old report, because I know that sometimes people have gotten things wrong on the prior study, or they did the prior study the wrong way, and they may have come up with the wrong conclusion. So I don't want to just blindly repeat things because they were on the prior report, the radiology report, because I know that sometimes those prior reports are helpful and sometimes they are hurtful. So I want to remember that all the time. I do go back and try to look at the prior studies and their reports, but I don't necessarily believe everything that they say in there. I want to be sure that what I'm looking at matches those prior reports. And I don't even believe myself from a study from 10 or 20 years ago if I have a prior report that I did on the prior study. So just as an example, here's a case of a study that was read out as unremarkable. This was a patient who had a oropharyngeal squamous cell carcinoma, and they got radiation and chemotherapy, and they came back a year after they finished radiation, and they had a sore throat. That was their complaint. And they had a positive retropharyngeal lymph node that was missed on the study. And the next year, the patient came back, and they still had a sore throat, and they had a follow-up study done. And on the follow-up study, they still had a pathologic retropharyngeal node that was missed on this study. Unfortunately, that patient came back a year later, still for a follow-up examination, and they had another study done, and they had a positive retropharyngeal pathologic lymph node on that study. And they were still complaining of a sore throat that was getting worse. These retropharyngeal nodes are very difficult to evaluate, obviously, on clinical exam. So it's our job as radiologists to find them. And we think not only about nasopharyngeal carcinomas, but also oropharyngeal and hypopharyngeal squamous cell carcinomas that may go to these retropharyngeal nodes. The problem is, if we do not look for them, we will not find them. And if we just look at the prior report, which is negative over and over again, we may not see this lesion that over time, when this patient finally came to my shop and we did an MRI, it had already invaded the skull base. And I suspect in this case that each time the radiologist at the outside shop was misled by the prior report, which said normal over and over again, even though the patient had a positive pathologic retropharyngeal node over and over again. So that's an example of how it's important to look at the prior reports, but don't necessarily blindly believe everything they say. This is another patient, and over again, this patient had been followed up actually for 5 years, and this patient was actually followed at my shop, and this patient had been called a benign mixed tumor over and over again. And I looked at the study, and the fellow read it out with me, and he said it looked unchanged as a benign mixed tumor. And I was looking at this imaging study, and I said, well, this really doesn't look like a pleomorphic adenoma or benign mixed tumor. It looks like there's a bunch of flow voids in this lesion. It looks actually more like a salt and pepper lesion, like a paraganglioma. And we see how it's pushing the fat, so that tries to help us with our diagnosis. And it does cross the stylomandibular notch or stylomandibular tunnel, a space between the mandible and the styloid process. But the enhancement is also very different than we expect with a benign mixed tumor. And this was actually a glomus vagali, a paraganglioma lesion that was centered a couple of centimeters below the skull base. Now here, for example, we see a paraganglioma. On the pre-contrasted T1, it's very homogeneous. We don't see the salt and pepper appearance. Here's a lot of pepper. The pepper is the flow voids that we see on the T1 before contrast. We don't see any of that on this very solid paraganglioma. And it's a little bit different displacement. Here the fat is pushed a little bit more medially, and here the fat is pushed anteriorly around this lesion. So this lesion was actually arising from the carotid sheath or space, pushing the parapharyngeal fat more anteriorly. This lesion of benign mixed tumor is actually arising from the deep lobe of the parotid, and we see the fat is pushed more medially. So that helps me with that differential. Also, with a benign mixed tumor, we expect it to be very bright on the T2. It should be as bright as CSF on all our sequences. And we see this lesion, the glomus vagali, was not as bright as CSF on its imaging. It's actually a little bit dark. We want to remember that T2, just like ADC, is a rough marker of tumor cellularity. So we use that to help us on our imaging. So the prior reports are very important. We want to see what the radiologist thought on the prior if we have a comparison. But we want to remember to still be a little bit paranoid. Sometimes a little bit of paranoia is not necessarily a bad thing. I don't want to blindly believe everything I see on the prior reports. So next we have sinus disease. Sinuses are something just like teeth that we often ignore as radiologists. But we want to pay very close attention to sinus disease. We'll talk about it more in later lectures. But sinus disease can actually get very exciting very fast. So the idea to remember here is he thought it was incidental, but it's not. It's not. That's funny. So we want to remember that it's not always an incidental finding with sinus disease. We often look at sinuses just like teeth, and we kind of just blow off those findings. But it can be very important. So when I'm talking about sinus disease in my reports, I try to always use the word obstructive or the word non-obstructive in my impression. And I'm telling my surgeon, my sinus surgeon, if I think this is somebody who may respond to endoscopic sinus surgery or not. So I want to either use the word obstructive or the word non-obstructive whenever I talk about sinus disease. Now, in a lot of patients who have sinus disease, they frequently start taking their medicine, and they're always told, keep taking your medicine until it's all gone. But the patients frequently feel better after a couple of days and stop, and they end up like this patient, where there's very bad frontal sinus disease. And this disease actually went anteriorly and caused what we often call Pott's puffy tumor, an acute onset of a subperiosteal abscess within the subcutaneous tissues in front of the frontal sinus. But this disease also went back intracranially. It caused an intracranial abscess. And this can be very difficult to take out intraoperatively with that abscess material. This is that patient who had a bifrontal craniotomy, and all this infected fluid was actually holding the craniotomy in sight with this thick, gooey abscess that he had intracranially. This is another patient that we actually considered this patient for sedation for the MRI we did after the CT. So initially we did this CT, and the resident read this study out as hyperostosis frontalis. So he was looking at this unusual bone formation. But it really didn't quite look normal on the CT, and it almost looked like there was a connection here between the frontal sinus. So we decided that we needed to do an MR on this patient. So we did the MR, and we actually found a giant intracranial empyema. This patient actually had a frontal sinus mucocele that had actually gone intracranial and caused the giant, impressive intracranial abscess that was actually so big and had so much mass effect on the brain, it was actually causing herniation at the foramen magnum, and this patient had a syrinx intracranial. So this was actually a frontal sinus mucocele that decompressed itself intracranially instead of going anteriorly. And that was another case that intraoperatively ended up just having a big flow of pus and infected material that flowed down from his bifrontal craniotomy we see here intraoperatively. So we see that sinus disease can be very exciting very quickly. Here's another unfortunate patient. This is a patient who came in with a changeometastasis, and they thought the patient might have a very small area of ischemia posteriorly on their MRI we see here on this diffusion sequence. So they decided to work this up and look at the blood vessels on the patient. So the patient had a CTA examination, and they thought that there might be a little aneurysm coming off of the cavernous segment. So they did some fancy 3D reconstructions of the CTA study, and they said, yes, it looks like we have a cavernous segment of the carotid aneurysm that's coming off. They decided it was important to confirm this with a catheter angiogram study. So they did a catheter angio, and they confirmed, yes, there is an aneurysm. So they decided because there was an aneurysm that they should go and put a surgical clip on this aneurysm itself. So they did a craniotomy and placed an aneurysm clip on this aneurysm. The problem was that when they went in to actually put the clip on, the surgeon said that the entire carotid was just this friable material that just fell apart, and his surgical bed quickly filled in with blood, and we had a very bad postoperative experience on this patient with this diffuse ischemia, low density we see here on the CT, with blood products and blood within the ventricles themselves, because this carotid just fell apart. And unfortunately, what we had missed on this patient was that on his MRI, he actually had complete opacification of his sphenoid air cell. Here's a pre-contrasted T1 that we see very bright signal. We want to remember all the time, not a lot of things are bright on T1 before contrast, but we had a lot of bright signal here within that sphenoid sinus on the T1. Nose is dark, the nose knows, so this is before contrast, and it was very dark on the T2. This is very dark T2 signal, and fungal disease is one of those things that may be very dark on T2. It might look like an aerated sinus, but it's actually opacified. And if we had paid close attention to the post-contrasted imaging on this patient, we see that the other sinuses are actually enhancing, but this sphenoid sinus is not enhancing inside of that air cell. So this is actually fungal disease that went from the sinus into the cavernous sinus adjacent to it. So that was actually a fungal aneurysm. And unfortunately, we sent our surgeons to operate on basically a fungal mycotic aneurysm that was in the cavernous sinus on this patient. And to make it worse, if they had paid attention, that sinus was actually normal aerated just a few months beforehand when this patient got that fungal disease. So unfortunately, in this case, we blew off this fungal disease and we said some likely incidental sphenoid sinus disease. So the sinuses can be very important, and we can get some very exciting disease very quickly from the sinuses. So don't ignore the sinuses in our studies. So our next important top 10 is the importance of clinical history. So we have relationships and history with different people. This is my desktop support assistant, and I gave him my laptop to load some software on it. And when I got my laptop back, he had set this picture as my desktop screen. So now I had a history with this person. That was my history. So we want to remember to try to get as much history as we can. Don't read studies in the dark. And just like we said with the prior reports, sometimes clinical history is helpful and sometimes it is hurtful. Sometimes it doesn't seem to help very much. But in the head and neck world, we want to try to get as much clinical history as we can, because we know that helps us very much when we're doing those studies. So we want to get as much clinical history as we can with our studies, because then we're much more likely to say something helpful to patient care if we're doing head and neck studies themselves. So every now and then we get some clinical history that may not be obvious to or helpful to us. So this is an example of a patient. The clinical history said, bit by ferret on shoulder. So you don't know all the time if that's very helpful. Evaluate for CVA. Here's another patient that says attacked by pig, pain and confusion. I'm not sure if the pig was confused or the patient was confused, but that clinical history may be helpful or maybe not. We're also competing all the time with the internet and with clinical information. So I read out a study one day with a resident, and he was talking about facial pain, and he said that's a problem with the facial nerve. And I corrected him and said, well, no, actually that's the trigeminal nerve. It's the fifth nerve is facial pain. The seventh nerve is facial paralysis. And my resident proceeded to tell me, no, I looked it up on the internet, and he proceeded to show me this e-medicine website where it said that the facial nerve was responsible for trigeminal neuralgia. So we want to just be aware all the time that this is what we're competing with. There are all these internet sources that may be giving out bad information all the time, and we're trying to compete with all these websites that may be giving misinformation. This website talked endlessly about how the facial nerve was causing trigeminal neuralgia, facial pain. And if we don't have that clinical information, we may be very misguided on the clinical information and our reports. This was a patient that was read out as having all these masses within the subcutaneous tissues, and they actually thought that this was a strange lymphoma of the subcutaneous tissues. And I went and asked the patient, and she didn't want to admit it at first, as patients may not to be. We're all vain about our appearance, but this patient had actually gone down to South America where they inject a lot of different materials in their bodies, and this patient had actually had different cheek injections to try to make her cheeks stand out more. But it was misread because we didn't have that information, and the patient denied the information when we first went and asked them. So clinical information is very important and completely changes out how we read our studies. This is another patient. This is an axial CT of the temporal bones, and I was reading out this study, and it looked like a canal wall down mastoidectomy. It looked like they had cut down the back wall of the external auditory canal. So I called up my surgeon and I said, I'm looking at your patient. You've done a canal wall down mastoidectomy. And he said, no, we've actually never done surgery on this patient. And I said, no, I'm looking at the imaging. He has had surgery. And the surgeon corrected me and said, no, I know the patient and I've talked to them. They have never had surgery. And this was actually a cholesteatoma of the external auditory canal. And this is a rind of cholesteatoma that's left behind, sometimes called a mural cholesteatoma, like a lemon peel or orange peel that may be left behind in the surgical bed. And this needs to be resected, otherwise the cholesteatoma will just come back. So in this case, the patient had a congenital rest of skin in the wrong place. That all is what a cholesteatoma is. So there was skin in the wrong place in the mastoid air cells, and it continued to enlarge over time until it broke into the external auditory canal. And essentially, the cholesteatoma did an automastoidectomy on itself, but there is a rind of cholesteatoma left behind. But I was completely misled because I didn't have that surgical information. I thought this was a postoperative case. Now, I had this patient, and if this patient said something that's not really helpful, like rule out abnormality or rule out pathology, I could miss this on this axial and coronal CT of the temporal bones. So I called up my surgeon, and he said, well, the patient actually has pulsatile tinnitus, and there's a small red mass behind an intact tympanic membrane. And this is actually a very small glomus tympanicum, a small tumor sitting on the cochlear promontory that we see here on the axial and on the coronal images. But if I don't have that clinical information, I could clearly miss this patient. So if I get this study and it says rule out abnormality, I might miss this. But if I get the clinical information that there's pulsatile tinnitus and a small red mass behind an intact TM, I might be able to make this finding of a small glomus tympanicum in this case. If those are larger, it's a lot more easy to see this solid soft tissue mass sitting on the cochlear promontory here on this coronal CT and correlating on the axial. That's a more obvious case of a glomus tympanicum or a glomus paraganglioma, and we know that those patients will present with a red mass behind an intact tympanic membrane. So a very reddish blush, a red mass on otoscopic exam with these patients with pulsatile tinnitus. So that clinical information is very important. Now, we want to be careful that that clinical information doesn't lead us astray. This was a patient that reportedly was having facial pain. And when we asked them, the type of pain was actually in the external auditory canal. But this was thought of as trigeminal neuralgia or geniculate neuralgia, where the surgeon thought that there was a small branching nerve traveling along with cranial nerve 7 that might be contributing to this patient's external auditory canal pain. Now, we often think about the external auditory canal having general sensory with 9, but you may be confused with these different cranial nerves, how they have different connections in different areas. So they decided to do a surgery on this patient where they did a geniculate neuralgia surgery that they thought initially was trigeminal neuralgia. They did a posterior fossa approach, and they resected or lysed these small nerves along with cranial nerve 7. And someone asked me to look at this study later because the patient was still having external auditory canal pain after surgery. And if we look at the imaging findings, we see that this condylar head and TMJ are very degenerative looking. And this is actually TMJ degenerative disease. And this is a patient where the TMJ disease was leading to their external auditory canal pain. So you see on the condylar head on the CT, it's very irregular. That is significant degenerative changes to this patient's TMJ, and that's much more likely to be causing this patient's external auditory canal pain. Unfortunately, in this patient, they had a bad reaction to the intraoperative anesthesia and ended up having extreme vasospasm. So you see the big difference on this patient's collapsed view MRA, where all of the blood vessels seem to be constricted, and we had some diffuse ischemia in this patient. So we ended up having a bad outcome on the surgery that may have actually been unindicated. It's much more likely that their EAC pain was coming from their condylar head degenerative changes and their TMJ. So that's important to get more clinical information. So our next important area is anatomy. We think about the anatomy in the head and neck world, and we want to always think about paying attention to our surroundings. It's always very important to think about the anatomy in the head and neck. So this is an area where we not only spend time talking about the pathology, but we also talk about how that pathology affects the surrounding anatomy. So we don't want to be like this guy who's mowing the lawn and doesn't see this person reading a book, and he's busy looking at this woman's shoes and not paying attention to his surrounding. That's very important. We always want to pay attention to our surrounding anatomy. And it's interesting somehow when we think about pathology and how it interacts with surrounding anatomy. Here's an axial CT of the temporal bone, and we see the soft tissue mass that's pushing the ossicles out laterally. This lesion is displacing the ossicles, not destroying the ossicles like we see with this different pathology. So this case is a cholesteatoma that's destroying the ossicles that we often see with the cholesteatoma with some kind of osseous destruction, whereas this case that was actually a facial nerve schwannoma is pushing the ossicles out laterally without destroying them. So a cholesteatoma is more likely to destroy the anatomy next to it than a schwannoma is, a benign nerve sheath tumor. Another area where anatomy is very important is we think about the recurrent laryngeal nerve and how that nerve goes all the way down under the aortic arch. So if we have a left cord paralysis, we want to remember the nerve goes down the carotid space under the aortic arch and all the way back up the TE groove to get to the vocal cords. So we could have sheath pathology in the AP window or under the aortic arch that can cause a vocal cord paralysis problem. So if we have a vocal cord paralysis, we want to image all the way along that course of the nerve, and we might have a pathology like this aggressive thyroid malignancy that led to a vocal cord paralysis. So on imaging here, we see the spinnaker sail shape of the cord paralysis. We see widening of the thyroarytenoid groove. We see prominence of the piriform sinus, and we see anteromedialization and thickening of the aryepiglottic fold. Those are the secondary signs of a cord paralysis. So the only primary sign is the spinnaker sail shape. So that looks like a spinnaker sail that we might see on a sailboat that you might see there off Cape Town. This is the spinnaker sail shape of a cord paralysis that we might see at that location to correlate nicely with our CT findings. Now, anatomy is sometimes very subtle in different areas. One day I was here in my office and I suddenly got texted by my surgeons to try to help some anatomy in a complex case they were looking at. And they sent me a picture of their surgery. And it's very hard for me to think about this anatomy just looking at the bottom of the surgical hole that these surgeons had made. And they actually started FaceTiming me, trying to explain to me where this anatomy was. And it's very difficult for me to look at that image and think about exactly where that anatomy is on cross-sectional imaging. So I had to pull up this study. And again, just like we started talking about the importance of pre-contrasted T1, these surgeons had started in the sinus and quickly found themselves in the orbit when they were chasing this disease. And if you look closely here, these optic struts are very different. We see the bright marrow fat on this side, and over here we've replaced the fat at this location. And these surgeons had gone from the sphenoid sinus into that orbital apex. We want to remember that the CT scanner is in some ways just a big, stupid densometer. It's looking at densities of tissues all the time. And having marrow fat is very different than having infectious inflammatory tissue at that orbital apex right here next to the optic nerve canal. So we see nicely the optic nerve canal here on both sides. And we know that at the level of the optic nerve canal, where cranial nerve V2 is going, that's near the level of the supraorbital foramen, where cranial nerves 3, 4, and 6 are going through. And we'll talk about them more later, but if we think about sinus disease, we can have sphenoid sinus disease that goes superiorly and laterally into the opticocarotid recess, and that is right next to the optic nerve, and it's right next to the carotid and the cavernous sinus. So disease from these sinuses can get into the optic nerve and into the orbit, or it can get into the cavernous sinus very quickly. So the anatomy around this area is very important, and we'll talk about that more later when we talk about the sinuses in more detail. But sphenoid sinus disease that goes superiorly and laterally may get into the orbit or the cavernous sinus very quickly. Now, to finish up our last couple of areas, next we have tumor spread. So we want to remember that there's lots of different types of tumor spread, but it's not just perineural tumor spread that we talk about. There are other types of disease, and perineural tumor spread is one of the big things for us in the head and neck world and head and neck anatomy. If there is perineural tumor spread, as we see in this case, that is going all the way back and touching the pons, that is a very difficult area for the surgeons to palpate. So that's my job to tell them if there is perineural tumor spread going back and touching the pons. Because if that perineural tumor has already invaded the brain, that patient is probably no longer a good surgical candidate. But we want to remember that it's not only perineural tumor spread, there's perifascial spread, there's perimuscular spread, there's perivenular spread, and there's even transosseous spread. This is a very unusual case where we had a patient with a rare spindle cell squamous cell carcinoma of the sinuses, and this tumor initially got resected, but what we didn't notice initially on the postoperative imaging, there was actually replacement of the normal fat in the marrow. And as we followed up this case over and over again, there was replacement of the normal marrow fat. This patient was actually had tumor crawling up through the marrow of the lateral wall of the orbit and going up to the skull base, and that extended superiorly through the lateral wall of the orbit, the greater wing of the sphenoid, and then extended up cranially to involve the frontal sinus, where we previously had normal bright fat, and at that point it went both intracranial as well as in the subcutaneous tissues. So remember, there's a lot of different ways for tumor to spread. Perineural tumor spread is just one of those ways. So next is data. We want to remember the importance of data when we think about our cancer studies. And we don't want to be afraid to irradiate patients. Sometimes the low-dose techniques make it difficult for us, especially around the temporal bone and the skull base, to evaluate our patients well. So we don't want to be afraid to irradiate those patients. And there are some sequences like the puffy cheek and puffy throat where we can evaluate the lining of the upper digestive tract very easily and see those structures. So the puffy cheek is one of those areas where the tip of the tongue goes back and we can see air going back towards the retromolar trigone. So if we want to evaluate the buccal surface, the lining surface of the oral cavity, we can do that very nicely by having the patient puff out their cheeks. We can see that anatomy very well. So sometimes doing a second pass on a patient where we have them puff out their cheeks, it makes it much more obvious to find a lesion along the buccal surface. So I don't worry about radiation too much. I know that that puffy cheek sequence can sometimes be very helpful in evaluating those patients. So when I'm doing these cases, I may do a second pass with that puffy cheek technique. So if I know a patient has pathology of a certain area, like the gingival lingual or the gingival buccal sulcus, retromolar trigone, tip of tongue, the tip of the tongue or lip, or the buccal surface, I may do a second pass, and I don't worry about increasing the radiation because I know that's very helpful in these cases. So another area we might think about is the puffy throat. I know if I do a puffy cheek, I'll also see areas like the epiglottis and vallecula, ariepiglottic fold much better in those areas. So the puffy throat is another area where I might fill up these air-filled spaces and be able to see this anatomy very well. And we'll talk about the larynx in that area later. But just another case, we want to be sure we don't ignore the scout on all our studies. Just like the scanogram on the MRI, sometimes the finding may only be on the scout on our CT. This is a patient who came in who was a 22-year-old prisoner who said he had stepped on a rake and hit his face and had a headache. And his head CT was not very exciting, but on his scout examination, we saw that this patient actually had a key to his handcuffs on his in his mouth under his tongue. He was hiding. So don't ignore the scout on your CT studies. That's very important. So when we're thinking about data, don't ignore the scout, and remember that may be very important. So don't ignore the scout and know what you're looking at if that's the same also as what you send to the archive. So another area where it's important to get the standard algorithm sequences is when we do a CT of the temporal bones. So I not only do a CT of the temporal bones themselves, I try to get one standard algorithm sequence because it's always embarrassing when there's a large tumor right there next to that area. So that's another area. I don't want to be afraid to irradiate, and I want to be aware of what I'm looking at. If I'm only looking at the temporal bone CT, if they're sending the source images to the archive, there may be a standard algorithm that shows an obvious tumor that we may have missed on that sequences. So just to skip ahead and finish up, the last thing to remember here is pseudomasses and artifacts. We want to remember that pseudomasses and artifacts are also very important. And we want to remember that it's hard to beat asymptomatic. I can't make that patient more asymptomatic than they already are from a lesion that we're looking at. So the importance of leave me alone lesions is very important. Here's a patient where we remember these skull-based lesions and their pathology. It's sometimes called arrested pneumatization, but we want to be sure we don't send our surgeons after this. And we want to remember, again, this CT scanner is just a big densometer. I can measure density here, and if that measures -40 or -100, that is just fat. I don't want to send my surgeons to operate on an incidental lesion. I can't make that patient more asymptomatic than they already are from this lesion at that location. Another area that we frequently see pseudomasses is at the jugular foramen. A couple of times a year, I get a patient referred for a biopsy of a possible skull-based metastatic lesion, and if I look at it, that may just be asymmetric flow if one jugular foramen is larger than the other one. So that's an area I want to pay attention and don't send my surgeons to operate on a normal lesion. So that's a quick review of some top 10 head and neck imaging pearls in some important areas. I want to remember that fat is my friend. I want to remember with lymph nodes, it's not all about size. I want to look at the imaging characteristics of them. I want to remember to image all the way with cranial nerve evaluation. I don't trust anyone of the prior reports. I do read them, but I don't blindly believe everything they say. I want to remember sinus disease. It's not all snot. Sometimes that sinus disease can be very exciting very quickly. I don't want to read in the dark. I want to get as much clinical information as I possibly can. I want to pay attention to my surroundings and remember the important anatomy. I want to remember all the different types of perineural tumor spread. And I don't want to be scared to irradiate. I want to remember there's a lot of ways to image these patients. And I want to think about doing a second pass if I need to and not ignoring the scout. And I also want to remember it's hard to beat asymptomatic. Remember all these pseudo lesions and asymptomatic incidental lesions because we can't make our patients more asymptomatic and more incidental from these lesions they already have. So that's a review of just some top 10 imaging pearls, and I thank you very much for your attention. And I can answer any questions you may have. I think you can type in the chat window or put any questions into the question window if you have any.
Hi, Dr. Wiggins. I'll assign them as they come through. Hasn't any come through? Usually takes about a minute or two for them to type the questions.
Sure, sure. So that was just a quick review of some random thoughts over the past 25 years or so of my head and neck imaging career, not in any particular order, but we'll go into a lot of these in more detail in the follow-up lectures coming up that we have. We'll talk about them in more detail and think about the importance of how I use all these imaging techniques.
Yes, hello, can you hear me?
Yes, sir.
Rick, thank you very much for this exquisite lecture and the absolute superb expertise and your experience that you've made available to us. We're a bit over time, but it's so important. We'll leave the inboxes open for 5 minutes.
Sure.
Johan, are there any questions or any compliments or complaints coming in?
There's one question that came in. I'll assign them to Dr. Wiggins. Can you see them, Dr. Wiggins?
There should be something in your inbox.
Throat. So what I do is I have the patients hold their breath with their lips closed. So they're doing a puffy cheek. So if somebody says to me that they're interested in the buccal surface, the retromolar trigone, the tip of the tongue, the gingival lingual, the gingival buccal sulcus, if they say any of those areas, I think about doing the puffy cheek as a second pass. So I just tell the patient to hold their breath just for a couple of seconds with their lips closed and puff out their cheeks like they're playing a trumpet. And then I do a quick short pass through the cheeks. Now, we can do the same thing with a puffy throat. If I tell them to puff out their cheeks and hold their breath, take a big deep breath and hold it in, that's going to dilate up all the areas around the larynx. The larynx for us is this complicated cartilaginous framework with the mucosal surfaces draped over it. So if somebody says epiglottis, glossoepiglottic, pharyngoepiglottic, folds, vallecula, if they say any of those areas, I know if I do a second pass with a puffy throat, then I'll be able to dilate up those air-filled areas and see them much better. So that's what I do, the puffy throat in those sequences.
I think from a South African perspective here is that certainly in the public sector, it is very important to triage the patient very accurately and because the patients are booked as head and neck cancer, so it's a standard protocol, and it's very difficult to obtain puffy cheeks and or Valsalva maneuvers. And I think that's one thing that we should actually implement in our practice in South Africa is that the radiographers, the technicians, should read the referral report and try and implement the correct protocol.
Yep, protocoling is very important. I agree. So someone asked about sinuses and evaluating T1 sinus lesions. The paranasal sinuses and the nasal vaults are interesting because on the T1 before contrast, the tumor will be dark, the mucosa is dark, and the turbinates are dark. But on the post-contrast, everything's bright. The tumor's bright, the turbinates are bright, and the mucosa is bright. But this is where the T2 is very helpful because on the T2 as a rough marker of tumor cellularity, the tumor will be dark, but the secondarily obstructed secretions in the sinuses will be bright. So I don't investigate all of the T1 hypointense lesions. I try to look at it and see if the enhancement is similar to that of the turbinates and the other mucosa. So that's what I try to do to evaluate that.
The
T2
any role for diffusion there?
Yeah, the diffusion and the ADC. You want to remember that not everything bright on the diffusion is restricted diffusion. Not everything bright on the diff or the DTI is actually restricted diffusion. you want it to be bright on the diff or the DTI or DWI and to be dark on the ADC. So we want to be very careful that we look at both of those sequences. The ADC, just like the T2, is a rough marker of tumor cellularity. So that's very important when we think about pathology anywhere in the head and neck. So we can take that brain sequence, the diffusion or DTI, and we can apply it in the extracranial head and neck and see if a lesion is dark on the ADC and therefore is hypercellular and therefore is more likely to be malignant.
Thank you, Rick. Any more questions? We're running we're over time now. Johan, any questions in the inbox?
I think so far he's answered most of them. There was just
okay.
T2 hypotensis. Don't know what that means.
Okay. If there are any questions in the inbox, Johan, if there are any questions in the inbox, just pass them through quickly, and then we can conclude the session.
I think Dr. Wiggins has answered all of them. So, yeah.
Okay. So, Rick, on behalf of the RSSA and myself in a personal capacity, thank you very much for your time and your commitment to advance head and neck radiology in South Africa. We really look forward to your next lecture, which will be, I think, the 6th of April. We'll send a message out. And for those RSA members who have spare time and spare cash, just remember that there is the Utah Head and Neck Conference, March 25th and 29th in Salt Lake City. If you really want to advance your career, you have to invest in yourself and try and attend these events. Rick, thank you very much, and over and out.
Thank you, Leon. Thank you, everybody.
Bye, Doctor.
Bye.